We just wanted to thank you all for your time, and I know that many of you had a long day of meetings already. Some of you are working through the workday back at home, so we thank you so much for joining us for this very important and timely webinar. Apologies again for the technical difficulties we've had the last time around, but we're glad that you're all here this time. This will, as most of you know, be a live presentation and webinar presented for those attending the meetings in Portugal. So welcome to all of you in the room, even though I can't see you. This is Deborah. Yes, ma'am.
We are about 22 plus.
Oh, very nice. Welcome. Welcome, welcome. I'll be managing the technical side from here on the west coast of the United States. And looking forward to hearing everything that Pia has to say. Just a brief introduction of Pia. She's the Senior Manager for Development Practice at ADRA Australia. She has 25 years of experience in the development sector, and she has a keen interest in working across sectors to maximize the impact of ADRA's programming, in particular related to resilience and improved relationships between people. She's spearheading research initiated by ADRA Australia in the South Pacific to address non-communicable diseases. Non-communicable diseases, speaking of which, or NCDs, and particularly cardiovascular disease, cancer, chronic respiratory diseases, and diabetes are the leading causes of death in the world. They're responsible for 63% of the 57 million deaths that occurred in 2008, and they disproportionately affect low and middle income countries, which is where, as we know, ADRA does a lot of our work. Nearly 80% of NCD deaths occur in low and middle income countries, and Pia will talk a little bit more about that. I won't go into that. But the good news is that these are preventable, and ADRA has developed a program called LiveMore, which is a lifestyle education intervention addressing NCDs. And so Pia is going to talk to us about this program, NCDs in general, the program in particular, and the difference that it's making in the South Pacific. So Pia, just a couple more housekeeping items. I see that those online have already taken care of muting their microphones, but just be sure to keep that in mind throughout the presentation. And there will be time at the end for questions. But if you have any in the meantime and you are online, feel free to type them in the chat box and we'll do our best to answer them at the end. So, Pia, handing it over to you. Take it away.
Thank you. Thank you very much. When we tried last week to do the webinar, I did it together with the lead researcher on the program we're working on. And just so you know, I'll do her presentation as well because she can't be here, or she can't be online either. I was thinking that maybe I should make voices so that you can hear the difference, but I don't trust myself on this one. So I might actually read a little bit from time to time. That is her part of the presentation, so you're just aware. But welcome to those in the room, and welcome to all those online. For the rest of you that are here, if you also can take notes, just so that you have the questions for the end, so that we can bring together all the questions that we might have at the end. So I'm going to say a little bit. Deborah already said, yes, it is the leading cause of death in the world, and it is disproportionately affecting middle and low income countries. And many of these countries have this double burden on communicable diseases and non-communicable diseases, which is a huge burden, of course, on the individuals, but also on the economy of the families, but also even on the governments. Anyone here, well, I can't ask that question, I'll just say, so be clear. As you know, communicable diseases spread from one person to another, right? The non-communicable diseases do not. Although, I must say, and just kind of aside, is that we do have influence on each other. So even though it doesn't spread like that, studies show that if you are with someone who do exercise and do have a healthy lifestyle, you're more likely to have one. And if you are with someone who like their dessert, you are likely to share it with them. And so we do have an influence in a way. And the research shows that actually 2-3 degrees is very clear that you have an influence, but it doesn't spread just like that. You still have a choice. I will go further in say, so the NCDs in the Pacific Islands. So other Australia are part of the Pacific, and some of the countries in the Pacific are having a huge burden on the non-communicable diseases. In fact, it's seen more of as an epidemic, and it's 7 out of the 10 worst affected countries in the world are in, well, this South Asia Pacific region. The problem also is that people tend to get it at a younger age, and they die sooner than in high income countries. And I'm just taking a few of the notes that you can also read yourself. Of 14 million premature deaths occurring from NCDs, 85 are in low or middle income countries. This is particularly important to know that sometimes when we started working on this, people said, why are you even bothering? This is a Western problem. This has nothing to do with the countries where ADRA is engaged. But that is obviously, and you know that, that's why you're here, it's not true. NCD will be the major health challenge, both in terms of disability and premature death for the Pacific in coming years. And for instance, in Fiji, only 16% of the population is aged more than 55 years due to premature death, particularly caused by NCDs. And then, as I said, there is also a financial cost, and there are other costs for the productivity of the country that are huge, has huge implications. In particular, diabetes is an enormous problem in the Pacific, and in other countries in the world it's coming up also. 80% of people with diabetes live in low or middle income countries. The escalating rate of diabetes in the Pacific are of particular concern. So in the Western Pacific is the epicenter, with 1/3 have the diabetes. No, that's not true. That's where 1/3 of those who have diabetes are in that region. But it is actually true that in some of the countries, as many as 33% have diabetes. So I'm not sure how that came in here. But in Vanuatu, which is one of the countries where we have been engaged, 1 in 4, or 24% of adults have diabetes. In Fiji, 13% of adults have diabetes, compared with the official figures of 4.2 in Australia. And the problem also is that this is the diabetes 2. And for diabetes 2, people are younger and younger when they get it. And then overweight and obesity. For each of the 10 countries in the Pacific for which data was available, have 60% or more of adult population overweight or obese. In 6 of these countries, more than 75% are overweight or obese. And 65% of Fijian population is overweight or obese, and 30% are obese. In the of women, 40% are obese. And then more than 50% have high cholesterol, and about 40% high blood pressure. And overweight and obesity is particularly prevalent in the younger strata of the population, making this a critical challenge for the years, obviously. So these are some of the facts that we then have to then relate to. And we will soon. And then we'll just do a little bit of a swap, going in somewhere else, and actually include some data on Cambodia. The logic behind that is that we did actually also do a pilot in Cambodia that Anne was going to mention later. But the main focus of my presentation will still be on the Pacific, and particularly Fiji. So in Cambodia, do I have it? Yeah, I have it up here. 52% of the total deaths are due to NCD, so you see it's more closer to 50. But 80% have 1 to 2 risk factors for NCDs, and 10% have 3 or more risk factors. I'm just mentioning some of those figures because that means, and also we see that diabetes is on the rise, and we'll maybe get some reflection on that later. Okay, so with this background, just establishing the facts that, yes, the situation is critical, and we see that low and middle income countries are severely affected. We look at what is the solution. And it is interesting coming from a church that actually have known this for so long, what it takes to have a healthy lifestyle, and how it, at times at least, have felt like we have lost it, that everyone else are picking it up, those messages that we already knew long ago. But we know now, also from research, that we get confirmed that positive lifestyle choices has a huge impact. And it's estimated that 90% of cardiovascular diseases and type 2 diabetes and 1 in 3 cancers are preventable through healthy lifestyle practices. Okay, that is huge. Thinking of the fact that now the majority reason for dying in the world are linked to some of these, and then you see that it's actually preventable. It's also a huge potential. That means we can actually address the issue. And so most premature deaths are linked to common risk factors such as tobacco use, unhealthy diet, physical inactivity, and harmful use of alcohol. And so an example, for instance, in Solomon Islands, 45% of men smoke, and in Vanuatu, 43% of men smoke. Then you have the alcohol consumption in Fiji is 5.5 liters pure alcohol per year. Because I'm not so much into alcohol, I actually have a hard time knowing what that means. Anyone here who have studied more on alcohol, who kind of have a feel of, is that much or little? Not that I study as in how much you drink, but more like kind of general. Does anyone know your own statistic for your country? How it is? No. Okay. But what is interesting though is those lifestyle choices, of course. Exchange of healthy local produce for unhealthy high fat sugar Western food is prevalent. In 8 low and middle income countries, less than 20% of the people surveyed reported eating the recommended 5 or more portions of fruit and vegetable a day. So there is a micronutrient deficiency that are very common. Okay, so again, this is the background. So what is the solution then? And the church has come up with some various programs to address lifestyle issues. And one of the programs that has been promoted strongly through the churches in Australia, and I know also in the US and Canada and New Zealand and some other places, have been the CHIP program. And the CHIP program has now gone for how many years? Is it 20, 30? It's kind of been for a long time, right? And Huntsville were developing it, and then it was expanded. And then a few years back, Sanitarium and the the what do you call it, Pacific Division were buying I don't know exactly how they were doing that, but they took it on to further develop it. Renew the material, invest in the communication part of it, and update the research. And so they did a major investment, and then they developed this, and they further did research on the CHIP program. And so the CHIP program, which stands for Complete Health Improvement Program, has shown to be very effective. And it is both on primary, secondary, and early tertiary prevention. And the program it says here, 25 plus years, and more than 60,000 participants globally. And it has had good results, and it has been published again and again. And CHIP is a holistic addressing various aspects of health, including nutrition, physical activity, substance use, stress, self-worth, and happiness, to mention some. And CHIP consistently improves the top 5 risk factors for NCDs. Total cholesterol, including low density, LDL, cholesterol, triglycerides, fasting plasma glucose, body mass index, and blood pressure. So those we see consistently that these are reduced. We also see sometimes anecdotally, but sometimes also more systematically, other effects like reduced depression, people are sleeping better, people feel more energy at least, and lots of other reported benefits. So then we have this wonderful program that seems to be so effective, and then we have communication that come to us in ADRA and says, do you have any advice for what we could do if we were to introduce this to the Pacific islands and the countries? And we were having discussions, and there were some concerns about the program as it is, because the program, which is a 1 month, but actually 3 months program, 18 sessions. Are you still on? Yeah, just making sure. Yeah. And where you have video, you have a package where you have books, a book and a recipe book and workbook, and a water bottle and a pedometer. But this is a very guided program, but the material requires fluency in English, being literate. The images are rather Western. The references are Western. The recipe that are suggested are based on having grocery stores where you can go and buy whatever you need. So there are lots of things that brought up concerns, plus, of course, the fact that people might not have the technical equipment to do even PowerPoint presentation or the videos and all of that. So there were a long list of concerns, plus it is while it is very successful, it is an expert type program where you listen to those who are most educated. And that is one of the things that we in our program might have concerns about, that it's always someone up there telling you what to do, and we might look for other approaches when we work in development. So this is where ADRA came in then. At the moment, I'm just making a point here, at the moment the name is LiveMore. It turns out that someone else has parallel to this also developed something they call LiveMore, and we might have to look into the name again. But it's in here now, but we will work on that. So in order to make those benefits that we had heard about in the CHIP program available to people who might be living in more rural areas, who might be even illiterate and have a totally different context, we wanted to use another approach. And we had, or I had, experience working with ADRA Cambodia and other countries who were using the REFLECT methodology or approach. And I was wondering whether it was possible to use a methodology and approach like Reflect in the context of the Pacific, but using the messages from CHIP. So that's exactly what we were trying then to find out. And we were looking at, so as you can see on the map, we were looking at particularly Fiji, Vanuatu, and Cambodia. We also were looking at Solomon Islands, but there were some reasons we didn't follow totally through with that. And so we did a cluster randomized control trial back in 2014-15 that then I'll go to report on the results from. And then later we also did a trial in Cambodia. But I'm making, it's actually possible if you do a search to go online and see at least the design for that randomized control trial. So in 2016, I think it was, at least that's when we finished, no, it was 2016, we had in Cambodia in 5 locations, I believe, in the end. Was it 5?
There were 6.
6.
6 for this and 1 for the CHIP.
And then for CHIP, yes. So now we just say, this one is not so that you know the history per se, it's just to remind us how much goes into preparing for something, a study like this. So you have the ethics applications. I say it's January, that's when we started. And then we needed to do 4. So the university that was involved would have 1. So that was like cleared. And then each of the 3 countries at a time, so Vanuatu, Fiji, and Solomon Islands. Each one with their own expectations, its own processes, their own everything, had to submit these as well. So that's a lengthy process. So by, I think, September, October, we had the last approval, starting in January. A part of this is also contextualizing. So even though we had a program that was trying to be grassroots oriented and totally going down to kind of be a more bottom up using local facilitators, we still needed to know if there were differences between the countries that we needed to take into account. Definitely also when we went from Pacific to Cambodia, we needed to go through the material, well they needed to see if this was still appropriate, if they were culturally sending the message we wanted to. And then I've just mentioned one that in there also, Cyclone Pam. So for instance for Vanuatu, between 3 months and 6 months, we had Cyclone Pam coming in. Mention one thing particularly on that one, because as part of the Cyclone Pam, all the fields, all the produce were destroyed. That means that a lot of food were flown in from outside, white rice, a lot of sugary thing, a lot of, unhealthy food. And people reported back that they could feel the difference. They could feel not only were they devastated by the, what happened and they whole what they lost, but health-wise they could feel the difference, and we could observe it to some extent when we did this study. So that's quite interesting. We didn't have the numbers, so we can't generalize anything, but we did observe it. So I'll just making sure. So then what did we do? The program itself were structured somehow similar to the CHIP program in that it is 30 days and then it's 3 months to total. So we tried to do 11 sessions in the first month. Then there is a village celebration because we are celebrating the results, and then there's another 2 months when they meet once a week, and then in the new program there will be another then celebration. Did you do 2 celebrations or the only one in some of the villages? Well, you can report later. Yeah. So the point is also to have all these things, that incentives that when we have succeeded, we celebrate. So the first thing was always to contextualize the material, then identify villages that was part of it. We did 2 controls and 2 intervention villages in each country in the Pacific. At the moment, we are starting a new one where we have in Fiji 4 intervention and 3 controls. And in Cambodia, we didn't have controls, but as they mentioned, we had more villages. So the first part is contextualizing. Next part is identifying villages, then identifying local facilitators. So unlike the CHIP program where you have an expert telling you how to live your life and the research, you actually have someone who's identified from a village, 1 male, 1 female, and they are trained. And the requirement in terms of education is secondary education. And if needed, some basic understanding of English, but actually all the material is meant to be translated. So you have an extreme difference, actually, just so you notice. And the key to that facilitation training is that there is some part on content, but as much on methodology, so that they learn how to engage with people, how to use participatory tools so that people themselves can analyze and discuss and also come up with action points at the end. So very different idea, of course, starting from what people know, giving people an opportunity to discuss and find solutions, and then also bring in some new information. The new information is then very strictly keeping to what the messages in CHIP would be, because we know the research behind. So the facilitators don't give general advice. They are quite strictly keeping to kind of, this is the one they're allowed to. Just making sure that, so after the facilitation training, there is a new element now coming in, and that is that we do also agriculture training. So just prior to starting, there will be some gardening training, and it is a process of trying to identify what is being already produced and how can we supplement that so that we have a balanced, or at least available balanced nutritional value diet. And then we get started. And while we do research now, it's actually part of the program to do the measurement, because it's an integral part. So you do measurement by a medical team coming in at baseline, 30 days and 3 months. And that is an incentive to also make changes, because you can see your progress. And then in addition to that, of course, then the facilitators run all these sessions, and you have the celebrations. And then you have food demonstrations, and then you encourage people to do walking clubs or different things that would stimulate people to live their lifestyle. And that's basically it in terms of what it looks like. Just mention that we try to, in the program, we try to, back to some discussion we had at least in this group earlier in the week, we tried to choose methodology and approaches that were consistent with what we believe is also our values. So that we believe that people have knowledge and local knowledge, and we want to recognize it and start from where people are and have them articulate all they know and the coping mechanisms and other things, and then they get some new information, but they also then come up with solutions. I want, even though it does have a lot that also focuses on what are the causes of the, non-communicable diseases, it tries to focus on the solutions and your positive lifestyle choices. And in the training now recently, we also tried to train them on being sensitive for people with trauma and sensitive to and have knowledge about mental health. Just a few more pictures there. by the way, because this is research, there are very strict rules for what we can take photos on and what we do display. So most of this, for one thing, we do get consent, and that's another thing. Of course, before they even start the program, everyone explain the program and sign on to consent forms. There is a strict research protocol to follow, hopefully also followed. So these are just a couple more pictures. We do emphasize, though, that as a program like this, some people then get the idea that. So the facilitators are trying to know exactly what to say in terms of what the program is and what it is not. So it is an education program with the potential of prevention, arrest, and even reverse a lot of diseases. Particularly diabetes have we seen really good results for. But obviously we can't promise anything. The other thing, of course, is that we do have very strong advice on how people with diabetes need to be followed up by their own doctor and elements like that. We do have a referral system, so once, if we see any signs of someone struggling, there is a kind of a set-up referral system into the district clinics and further. So there is a very rigid evaluation or measurement on biometrics such as height, weight, waist, what do you call it? Yes, exactly. And then we have, we take the blood and we do the, this is a bit late in the evening for me now, so I'm just trying to get people engaged before they all fall asleep. The point was actually, and it might be a list later as well, the point was, in addition to that, we use what the people analyze in their own groups, as well as additional qualitative methodology in order to gather some qualitative data as well. And one methodology we do use is the most significant change stories, not alone, but as one. And we get a lot of stories coming up, and this one, and the size of this is representing how many times it's mentioned. So it's not scientifically, but just from, you know, a count. So typically people get more energy, feel lighter, feel good. But I love this one, can swim underwater for a longer period of time. And I, you know, obviously I need to say, so why is that most significant? But that is actually because they are collecting shells in the river. So the fact that you can stay underwater longer is an income source for you. You can actually earn more money based on that. Feeling fresh, feel clearer thoughts. Sleep well at night, I love that one. Can work in the garden, feel sharper, no joint pain, less joint pain, that's more. Blurry vision gone, now see without glasses. Lost 12 kilos. That is, by the way, something, even though lots of people lose a lot of weight, we try not to make it a weight loss program because they should not eat less. They should balance the size, but in theory, if you just stop eating for a month, yes, you would lose weight, but it wouldn't be sustainable. And obviously, our advice is to eat more of certain food, rather. I'm more present for my family. That, by the way, I do remember one that was reporting on that. We did see alcohol consumption go down in some cases. We clearly saw a reduction in, we didn't see it, but we heard about it, about tobacco use. Blood pressure down, stop snoring, can walk again. Can walk again actually came up several times. People who hadn't been basically outside their house for years now all of a sudden started gradually walking. And must admit, though, that we got some spouses reporting and said, the most significant change for me is that my wife is actually now able to walk. So, of course, that was huge for them. So, and because this happens to a large extent in 30 days, it is actually quite overwhelming when you see it really happening, and then 3 months even more. Just quickly on the study design as well. Just sorry online here for moving a lot of paper. Yeah, just before I do the study design, so instead of, so there's no videos, there's no technical equipment, it's all local facilitation using flip charts and markers and some, you know, yeah, basically that. Few more props, but not much. And so that is a huge contrast. They do get the pedometer, though. We do suspect that the pedometer do motivate people quite a bit for walking, particularly initially, from the feedback we got. So we are continuing doing that. They do get a notebook, so that when they do this self-analysis and stuff, they put that and use that even to improve their literacy. So yes, so that's what they get. Study design. So to evaluate the efficacy of this newly developed program and pilot study, we used a cluster randomized control design. So it wasn't randomized in the people who participated, because that was the randomized part was in selection of the villages. And then within the villages, there was a call through the village chief for eligible participants in an information meeting. And then there was a pre-screening and then another confirmed through baseline. So some of the things here is that this is referring back to the initial study. And so we would have 2 controls to intervention, 2 facilitators trained from each village, and we had 24 people. Initially, we did strictly on women and men equal numbers. However, we didn't find it necessary for the next study, because there didn't seem to be a gender difference in terms of it wasn't required to continue to have that strict balance for this study. Just see, there you can see what we did in terms of measurement, biometrics, height, weight, waist, BP, pulse, fasting, lipids, and glucose. And then we did a questionnaire. And we did that in both places. Then obviously we didn't do the intervention. So the only thing that happened in the controls were that we did the measurement, and they got leaflets from the Ministry of Health. Things that were already produced, so we did not produce it for them. But if it was available, we actually brought it with us. Then we had a little bit tricky thing, because the research teams were supposed to give feedback on the results, but not give advice. We found later that in one village particularly, there had been quite a bit of advice with the results in the control. So some people had got really eager to do some changes, because they had already then got some oral, verbal advice as well. That didn't sustain though, but it was enough. And the way I picked it up was through most significant change for those who had most changes after 30 days. So I went and interviewed them and said, oh, wow, this is in the control. What triggered the change? And they said, oh, we got such beautiful advice at the beginning. So then all of a sudden we went back and found that, yes, actually, the research team had in fact been a bit generous with their advice That has now been clearly stated not to happen again. Because they will get the results, but not with advice. And then at the very last results, they can get advice, but for obvious reasons, not before. Just a reminder, as I said, ethics are needed. We did that with Cambodia as well, right? So we did that in every place we've been. Okay, and these are for the very specially interested. So statistical analysis, so that you can just see. So we're not going by people who feel better or feel even more energy. We are very careful to also look at what does the blood tell us, or what does these measurements tell us. So we are doing a quantitative analysis, and it's analyzed using SPSS. And we're looking at the extent of change, as you can see, percent in the mean with a 95% confidence interval from baseline, 1 month and 90 days. And you can see there, and we have the cut points for each of the biometrics. Okay, you see? So, so we try to use, well, I guess normal standard for research in this field. And now the results. And first, the results were quite disappointing, to put it mildly. Because, and I'll get to that. So to say the least, these results were quite disappointing. So if you look there, so even though the numbers were going to be small, we decided to look at each of the villages' outcomes separately. Remember, at this point, we actually, when we first looked at it, we actually didn't know all the details about the advice from the research team also. So what we saw was that it wasn't great. So then when we took it down, so we didn't want too much, or we hoped that not too much would happen in the control, or that was our expectation. And then we had what I just mentioned before. Well, a little bit more happened than what we would expect. But that was then, we could see the linkage, and it wasn't sustained. Well, we suspect that's the linkage. And then also the results were very disappointing in one of the villages, in one of the intervention villages. And then we had to go back and actually find out what exactly had happened. And it turned out, because some of these were not reported very well back to us at the time, so there was a delay in us getting feedback on some of the issues that had been there. And it turned out that one of the two facilitators had dropped out. The remaining ones were very young in experience, had failed to actually get people to come to meetings. So even though we knew that there had been meetings, it turned out that there had been maybe 5 or 6 people coming to those meetings. And after 13 out of the 18 sessions, they totally stopped. So, well, in a way, it was then good to know that when you don't do the program, you actually don't get great results, seen from if you start judging it. Because when we looked closer then on the last village, village 2 of the intervention, the exciting results, however, were found in the second intervention village. Significant reduction were found for all biometrics at 30 days, except for pulse, total cholesterol, and triglycerides. By 90 days, there were even greater improvements. And that was particularly encouraging, because there is a danger that people can do it for 30 days, and that's it. But the fact that in many cases it was actually improved further were very, very encouraging. And you can see over there some of the results, the yellow marked.
What are the single versus double asterisks?
Oh, then I have to have a look. No, I can't see. This is where Lillian would have been helpful. I think it was okay, yeah, I do remember. Yeah, no, you can take it afterwards because I have the paper as well. Okay, so these are the results separately. And then another interesting thing is to then compare how is this program comparing to when you do the CHIP program, doing a different methodology somewhere else. And so here you can see some of standard CHIP and this reflect CHIP merge. You can see some, you can compare some of them. So you have in BMI, not as much. So you can see Australasia. You can see on BMI it was a little bit lower. On blood pressure, you can see it is actually higher than a lot of the others. Can you see? So you have PG over here. So these two are representing the for you online, it is the two right columns. So as you can see, if you compare some of them, so your blood pressure a lot, but also relatively successful in terms of total cholesterol. There's one that we are going to find out more, but we also know that this is one that is hard to measure, is the triglycerides. So that's like what's happening here, because it's actually increasing. But yes, so this is what we have to go by, and this one is what then triggered us to go back to Fiji, get higher numbers and more controls, and so that's going on as we speak. They're in the midst of doing their baseline at the moment. In 30 days, we'll know with a larger number if it's actually successful. So this is initial findings indicating that it might be successful.
In the new groups in Fiji, how many villages or how many people?
Yeah, so it's 4 villages, 100 people. So from 44 till 100. And we also go more strictly on high-risk cases. So we have been more strict to exclude anyone, I hope they're supposed to have done, in terms of high risk. So we have using rather strict standards for high-risk cases, but a lot of them are based on the, for women, yeah, I think it is. No, it's not BMI. It's actually the 80 centimeters of around your waist, or 92, I think, for men. As one of the kind of, and then you have other risk factors. So if you know that you are a known diabetes case or others, then you are in. So now, Anne, if you can come over here because we have a microphone. So Anne Stickle is here from Cambodia for you online, and she was part of the program in Cambodia.
Okay. Yeah, thanks, Pia. And as Pia already said, the process was pretty much the same, except we didn't do the control group in Cambodia. And we had 6 groups. 3 were village groups in our and another project that was focused on health and nutrition. And so facilitators who had already been trained did those. 2 groups were in 2 villages where there's small churches, and the church leaders were trained as facilitators. And 1 group was in the ADRA office, the ADRA staff. And a bit like Pia was showing with the differences on the 2 Fiji groups, each village had differences. There was at least 1 village, I was just looking at these results, where there was improvements in almost every area, several of them, But for example, just looking at the HDL cholesterol, high is good. In 3 of the villages, increased almost 20% and 1 over 10%. And in 3 of the groups, it was basically 0. So basically, we found that our monitoring of the facilitators or their initial understanding was different among these 6 groups. So each group had some improvement in some area, like a lot of exercise in 3 of the groups, and they did really well. Other groups, a lot less meat, a lot more vegetables, and they did really well on reducing the LDL cholesterol and improving their blood sugar. But the main thing I just wanted to share wasn't so much the numbers, was more about the change. This is really a deep behavior change strategy. And if we go back, there was a lot of people's lives improved. There was 100 people who participated. We also had problems, at least in some of the groups, where we had only 58% regular high attendance overall. So we had the same issue. We can look at that by each village. But those who attended really changed. When they were together, working together for those 3 months, they have really made a change, and they continue to sustain it. I just saw one of the facilitators the other day, and she said, yes, I'll change. A particular thing that happened was we had a short meeting near the end of the project looking at the facilitators' results per group, and just saying, why wasn't this better? What happened in your group? And they said, well, the people weren't coming, and I couldn't get them to come. But they said other people in our village were coming. They saw that those who were coming, their lives were changed. They were walking more, just feeling better, and they saw it, and they came and said, how do you do it? Can we do it? And I had to tell them, you can't join because this is a research project and whatnot, but here's what you can do. And they said there's a lot more people in our village who are changing their lives also that just aren't recorded here. You can't see the difference in the paper. So that was just one thing.
Thank you. Thank you. And so, yeah, once we get through this control trials and get that sorted, it will be very much more flexible. And I'm looking forward to getting there so that we can have a much more inclusive way of working. We have had other places also. At some sessions, they doubled the the number of participants were doubled because the village knew that it was a topic that everyone wanted to attend, and so they just came. We had people coming from other villages, and it was heartbreaking because there were people hearing that I came in for the evaluation, and they walked for hours to come because they had heard about the results, and they said, it was like, come over to Macedonia and help us. It was like, please, please, we have these issues. Please, we see these life changes, and this is life and death for us. Please, please come and help us. So, and it was actually more than one. Not that that's a significant number, but it was really significant for me, and it was heartbreaking because we weren't ready and we didn't have the budget at the time. But I believe that if we can actually show that the model works. And now we have 3 countries that are willing to go if we can secure the budget. So Zimbabwe and Ghana and Nepal are ready to do study now this coming year if we can secure the budget. We will continue to do Fiji. Vanuatu will come later in the year. And with all those...
And Cambodia.
And Cambodia. Okay, see? And so if we can have, a good spread of really committed leaders who follow this through, and we can see that it works, I think we can have a really, really good program to bring to the world and actually make a huge, huge, huge difference in the world. So now we are, this was actually how we selected. You don't have to worry about that. Q&A. So, Deborah, have you got any questions at your end?
We don't, so we'll let you go ahead and take any questions from the room, and I'll let you know if any come in.
Any questions? It is not the time of the day that might trigger questions, but we are here. Okay, we do. Okay. Yes, please.
I just had a quick question about the feeding programs.
Yeah.
I know that in Islander communities, family is a very strong component to life in general. And I was just curious to know what was the family involved. I know that like family reported back to you saying like, you know, it's great to see my wife getting up and things like that. But was there anything in the programming side where family was meant to be involved, like getting the family to participate as well?
Okay, so this has been a little bit tricky due to the research, because in a few cases, actually, both the husband and the wife were in the program, and that's where we got the feedback. We are looking at places where we could actually open it so that we are inviting couples. It's just that we can't manage the numbers at the moment. We do know that if you have a body and someone, in addition to have the group, you have one person that you particularly engage with, that is a huge benefit. So we are kind of looking at how can we make that possible. There is a place where we do encourage people to, in the groups, just find someone who will encourage you the next week and the coming weeks. But we haven't been able to find a way so we can double the numbers at the moment. But yeah, it's a very good point. We do require, though, that they themselves or someone can commit to making the change in the diet. Otherwise, it wouldn't work. Yes, please.
What do you think is going on with the attendance issue? And what ideas do you have about dealing with trying to increase the attendance?
We have done a lot on that side. So what we saw was relatively young facilitators with very little power, whatever you would call it, seemed to be struggling. So we were trying to make up for that in the new project in Fiji. And what we got was that we got 3 out of the 4 are village leaders. And we have like 4, I think, village volunteers. So all of a sudden, because we were kind of pushing that a little bit further, we got like, we are going to power this up. And so we got people who have a lot of influence. The question now is, how are the village chiefs going to be facilitators? And it was a very interesting experience because we were doing facilitation training and it's a servant leadership type. And for many of those village chiefs, they had never been operating in this space. But it seems like most of them found it very interesting and inspiring because they said, oh, we never listen, we tell. And so it was a new experience for them. So maybe we will do more than just change people's diet.
Another thing that we are thinking of doing is the champions. I know that you talked a lot before about champions. Now that people have gone through it, there's a lot of people who really believe in it. At the beginning, no matter what we said, until they saw it with their own eyes, they didn't really believe it. So making sure that the facilitators are real champions before it starts, I think will also make a big difference.
Yep. So they start when they do the training, so that at least they have got exposure already. Problem with that was for us actually that they wanted to go back immediately, even before baseline, and start changing the world. So for research purposes, that was a little bit tricky, but they were already telling everyone. Yeah, Steve.
Just on the facilitators, the traditional CHIP program and the one that has been revised by SPD tends to have all materials available, and the facilitator is more of an encourager.
And you press the button.
Yes, and the material flows. You know, you don't have to be an expert. Certainly in this, when you go down to local level, you are going to need to do a lot more training to get them to a level where they feel confident, where they're able to relay the information as well. And so that is certainly going to have an impact on their outcome.
Yes.
Isn't it? And so my questions are, how much training do you do? How do you select your facilitators? And how do you make sure that the message that's coming out is the correct message?
Okay, so very good questions. So we do have criteria, so they have to have be respected in a village and recommended by the leadership, and they have to have a burden for others' health and commitment and a few things, and they need to have communication skills, but we don't require a very high education. But they need to be able to read in their local language, because that's, in addition to using using verbal training, they also need to be able to access the information that we provide. That was part. So we do a 1-week training. Part of that training is they go to actually a village and try and practice, and that was probably the biggest before and after. So they get to try it out in a real, in a non-participatory village. We do, in the budget, we set aside time, so there's a very close follow-up from ADRA in terms of presence. So it's I think it's 1 to 2 times a week in the first month for each village. It's together with the food demonstrations. So there's a very close presence for that. The participatory methodologies are kind of open, and so that's not so critical in terms of what they analyze. But in terms of content, it is very much like, it's very instructive. It says very clearly what you need to cover, and they have very clear instruction not to go beyond. The good thing is, because they are not doctors, they don't think they know everything in the world. Oh, sorry. And because we emphasize it a lot, and there are 2 people in the room, we don't know that there is something terrible has been said, and we are very, very clear about the messages need to be strictly this. And because it's focused on behavioral change, so basically smoke less or smoke not, don't smoke. Yeah. The closest I got to a problem was actually one visiting nurse when we did the training, who wanted to make sure that at least we could drink a little alcohol. And he was starting to argue that his doctor had told him that was very healthy. And I had to remind him, for this program, please, you just follow what it says, because we have the research behind, and you have to follow through if we are to roll with this. But he wasn't a facilitator. Yes, Mark first, and then Jose.
Just to add, following up on Steve's comment, the facilitated program, as compared to the video, does not rely on a lot of scientific evidence. It's basically just promoting fairly simple behavioral messages and saying, they work, they do this. This will reduce cholesterol. This will reduce blood pressure. And it's not. They don't have to quote. They're not quoting a lot of statistical or scientific medical verification.
So we tell the facilitators, of course, that this has been researched, and that's why it's important to stick to the message. But it is not research heavy. And then we use some trigger pictures. So that's one of the tools we're using, where we just show how your blood vessel looks like when it's almost, totally cluttered, and things like that. So we're almost there. Do we have a couple of last questions?
Yeah. I wanted to know what level of coordination was there with the Ministry of Health, with the local staff of the Ministry of Health, the health facility staff. Yeah. That's one of the things. Then about the participants, 2 questions. Their age, if there is any average.
18 plus.
Okay. Because usually it's more difficult to engage younger participants. The older ones are usually more eager to know the programs. I don't know if you have experienced that here. And if there was a way to make sure that these participants were not exposed to a previous similar lifestyle program.
Yeah. So we tried to, go to the last one. So we tried to find out if there has been similar programs. and we tried to avoid that. We also had spreads so that they couldn't have, so that they were not, the proximity of each village is not so that there should be any interactions per se between the control and the others. But we don't have a full control on that because some of the nurses might have been exposed to some training by now. The first question, so the reason why we say 18 is because of research. We don't want to get into the whole issue of children. The very first question was...
The coordination with the Ministry of
Coordination, yes, very close, particularly to Pacific. So we meet with the Ministry of Health Department for non-communicable diseases. We have kept them informed now throughout, and they are waiting for the results. In fact, they are eagerly waiting for the results. And we have already got indication that the person in charge is saying that this might be the program that will take to scale and is used for the whole of Fiji, for Fiji. Can you just quickly say what you did and how you interacted with other stakeholders in Cambodia?
Yeah, we definitely did the same thing in the Ministry of Health, non-communicable diseases, and we worked very closely at the provincial level with the provincial health department. And
afterwards?
Afterwards, we had a dissemination workshop, and we had all the WHO, the Ministry of Health, and the provincial health department. They were all there, and we had the news and shared it with the ethics committee as well.
News, as in news on the TV.
Yeah, on the TV. And everyone really liked it and is eager for it to continue.
I guess that was that the last question? No, it wasn't.
No,
oh, there are more. Okay.
Okay, I'm listening to the various results that you mentioned in the studies. Some of the questions I had are already answered by after some other parts. Looking at you mentioned that as you observe the results in I think you want to as a first study, that the participants were influenced by outside material, and so by the time you're ready for the analysis, you had folks who were influenced or who may have experienced change, and it's interesting that you said that folks who were in control, they were the ones who seem to have been given like pamphlet or all the information from some other source. In that case, how are you able to adjust in your results? How are you able to adjust for that confirmed in the results? Normally, you want to say that a change has been attributed to your intervention. But in this case, you got evidence that persons probably were fed information outside of your program, so that in terms of coming to conclusion, in terms of the effectiveness of your program, you may have a challenge there in terms of saying that these persons' behavioral change or changes were attributed to your program. How do you manage that?
Yeah, so actually it was within our program, unfortunately. It wasn't actually. So what we wanted to give them available pamphlets, leaflets, whatever, from the Ministry of Health. So because we didn't want to hold back, we wanted to share. So we already knew that there could be a little bit of effect from that. But what we got the effect from, because what I did then, I looked at the results and I identified those who had actually changed in the control, and I interviewed them. And I said, wow, great results. What do you attribute it to? And I said, it was the advice from the medical team that inspired me, because they gave me advice based on my results. And so we knew that it was the research team that should have just given them the numbers and not given them advice on how to make the changes. And so they themselves were the one telling me, and since I did several interviews, it wasn't a lot of people who changed, but they had actually a few of them had been very, very eager, so they did it quite well, but they didn't actually sustain it. So after 3 months, we saw no difference anymore.
Okay.
So, but for other villages where there had been no such thing, basically we didn't see any observable changes. So, but that's something that's also one of the reasons why we do a control now, is that even though we think, because there seems to be a correlation, we are definitely now with more instructions for the medical team, trying to then get it right this time.
Well, and on that same question, on the same point,
yeah.
At any point in either the studies in Fiji or
Vanuatu.
Was it Cambodia?
Cambodia or Vanuatu, yeah.
At any point in the selection of the participants,
yeah.
were they told which group you were in, whether they were experiment or control, or how do you say, okay, this group is control,
yeah.
this group is, how did you really
So all in the initial study, all the villages were approached with the potential that they could become a control or a intervention.
Okay.
And we talked to the leadership. And once the villages with relatively similar demographics had been collected, so it's not random in terms of the participants, but it's the random selection of the villages. And then we draw from a hat at the, basically. And so, yes, so they just became, and then once they were there, they knew what they were. They knew that they were, but they didn't know what the others were doing. They just knew that they were coming, they were invited to do the blood testing and to get these leaflets and be part of a research. One more.
I thought it was really great that the ADRA office was included in Cambodia, and that, is something for all the ADRA offices to think about, and even maybe doing a control, with another NGO or something. Would be very interesting. It would certainly spread the news fast around the NGO community.
We do actually require that everyone who's directly involved will follow, right? So, for instance, when we hire someone to look after the program and the facilitators, they know that they commit to actually follow the program as well. So it's meant to be kind of a role model and having the experience, not the least having the little bit of a pain the first week because of the withdrawal symptoms.
So as we think about our range of 130 plus ADRA offices, what kind of criteria does an ADRA office need to consider on whether this is a good fit for their office, for their populations? What kinds of things do they need to think about?
Maybe ask the officers that's involved, because from my side, particularly at this stage, it is if the leadership is highly committed, that is what I need. Because unless that is like, this is not the normal program and if we are 3 weeks late, that's okay. It needs some rigor. And so that's where the critical part is. So when that's there, we can have more programs going. And then, of course, they need to know the potential in country. So if they know that there is a potential, so we have countries that know that, yes, our country is ready, then we are ready.
So we can take response to your question as well. It's a good question to ask here, but if you look around the network,
yeah.
We have different cultural situations that you look at. Now, I was listening to hear if, along with your own adjusted or created program, if you think that in some parts of some of these countries, let's say in the cities, for example, you might want to apply different methods than you use in the country areas in terms of who are involved and so on. So the chip, per se, might be run well in a setting where people are qualified. You have doctors and so on to run it. And in some countries, actually run chip right now. They're running right now in the Caribbean. We have some folks on, they're running those programs with the regular chip stuff. So I think that will be a question that will depend on the needs of the country, and of course you'll need the commitment, let's say, from administration. Another point is I sense that you aren't too happy with the fact that results weren't so good in some areas. Now when you're doing behavioral change programs, don't expect 100% or 90% change one shot. I think based on what I've seen, I think the program did fairly well in terms of what to expect in behavioral change programs. So it's some more effort, some more fine-tuning, you get there. But change for behavior is not easy to come by, and so you should applaud yourself for doing a good job so far.
Yeah, thank you. Just mention that, yes, we actually, even in countries where we do the LiveMore version, we try to have at least one program running, even if it is for the upper class.
Excellent.
Because we want to engage with Minister of Health, doctors, people who are maybe better off also, so that they can experience that change and have an understanding that we want this for our country and can support us in this. So even in countries where it's not obvious, we will still run it in the cities, but because demographic often ends up being a little bit upper class, we would probably not be running it again and again and again unless it is an English-speaking urban setting. Then we could consider it.
Very quick comment, just that support by the country office needs to be the country director doing the program.
Yeah.
Needs to include that. So any office that really wants it, you need to actually do the whole program. And I can say personally, and I think for Mark also, it was a very good review for us in behavior change.
Yeah.
Seeing how we went through that behavior change and all of those around us, it's very good.
Yep. And Steve?
Just on the behavioral change bits, 3 months, 6 months is not enough, really. It has to be consistent even longer than that. And that's why my question would be, what is in place to continue that on?
Okay, so while we do focus our research on the first 3 months now, we actually have a monthly meeting after that in the program's design now. So they will have what we call similar to the CHIP Club. Then they meet monthly, and then if we have money, we will actually measure after 1 year. It's just that I don't want to push it at the moment. We are going to do it. And it is already written into the ethics even. But because we are not there yet, I wasn't pushing it too much, but definitely a good thing. So the idea is, because it's similar to Reflect, there will also be a shift in setting the agenda more and more. And there will be resource material, but they will be a little bit more flexible in terms of what they address. And we are thinking finance, budgeting, household budgeting, even domestic violence could be one. It could be, a variation of things they would do in the follow-up. More and more. Okay. Yes, please.
Thank you very much. I'd like to appreciate the research that has gone in, because as other countries, we have actually been looking for programs that we could work with for non-communicable diseases. I think I updated you with Zimbabwe.
Yes.
We have been talking to WHO, we have been talking to the Ministry of Health, Department of Non-Communicable Disease, and the thing that came from WHO was, do you have an approach that you would want to use, so that maybe that approach, then we can start somewhere. So I think with that kind of a program, I could see that it's built in it that we can actually look at the setting of the country, adopt and adapt the program to suit the context of the country that we're in. So I think this is a very good beginning for us to work with. And I think there would be variations depending on the cultural and other issues that relates to the country of operation. But I think it's a very good start for ADRA.
Okay, thank you.
Just talking on a couple of comments. Oh, sorry.
Yeah, no, you go. And then I'm just making sure that she left.
I know that you need the country office support to start this off, but given the fact that in the Pacific, NCDs are such a problem, and they're a growing trend in general as health issues, just as things are going on, is ADRA able, I'm new to ADRA, so I'm not quite sure how this works, but is ADRA able to go into other Pacific countries where there currently aren't any ADRA offices?
Okay. Now I'm going to introduce something else. So ADRA has taken on board Open Heart International, who used to come out of SAN, which is the Sydney Adventist Hospital. They are in it for many, many years. They have sent teams of medical teams overseas to train locally, but at the hospital level, right? okay, now when we have that relationship, we also have access to countries that may even not even have ADRA. And so we are looking at, because they, even though what they often focus on, even if it is related to cardiovascular diseases, may be children who've been born that way, but it still increases their competency in area in surgery and post-surgery care. So what we try to do in those countries, we are looking into models where they do that, then maybe we just engage directly with the church in those countries and work out to the church. So we are trying to find out how that could work, but we know if there is an ADRA, trying to force it prematurely doesn't work. So unless it is a desire for ADRA to take it on, and with the church, closely with the church, we don't want it to fail because we believe it has such a potential.
I believe that, but my last point before, you mentioned engaging the ministries of health. Now, based on my experience working with those ministries, if you want to get, I can see this program has potential, as was mentioned here, of being the strategy for the country, and that's which comes from ADRA. I want to just advise that as you plan to go to the next level to engage in ministries, they want you to present them with facts, because they have to present these things to the committees and to the governments and so on. You've got to make sure you have a body of data from these studies, and that you can make certain, let's say you make some analyses that are fixed, and you say, look, based on having done this in country A, country B, country C, these are trends we found. And when it can be so convincing, you might very well be able to get the ministries buy-in.
Yep.
So the advice to you is as you work along trying to build partnerships with them, that you try your best to make sure that you have your end of the bargain well covered, so that if they ask for evidence of past experience and past success, you can present those to them right away.
Yep. No, it aligns with what we're saying. Yes, please.
Okay. In collaborating with the Ministry of Health, I know in certain countries they have diabetic clinics, and if they want to leverage on the program, what would you advise would be the relationship between ADRA and the ministry?
Yeah, because we usually then will listen to what the Ministry of Health are advising us, but because we have referral systems, so while we are working in the community with the non-medical people, they're usually very happy for us to then have the next level referral, either through clinics or directly, if it's diabetes cases, to hospitals where you have programs run out of hospitals. But the uniqueness here is that it's actually happening in the village. The facilitators live in the village, and that usually is a slightly different model from what is run out of hospitals, at least so far we have seen. So the only thing is we actually try to be aware of it and then refer further. But we do see, though, that nurses are very eager to come to our training. So it might actually be in the future that we will have to find a way to actually say, yep, this is for the facilitators and this is for the nurses, because they are just, they want to be there.
Knowing what we know in ADRA about adult learning and participatory techniques, and etc., why not try the live more in the urban setting among the elites, or even in the US and Canada?
Yeah, it needs to have a community type setting, but we are going to in I think it is in Zimbabwe, that we will try to do it in settlements or in slum areas. Actually, it's a neighborhood, definitely not higher up, but it will be an urban setting. We are trying in Fiji and other places to have it more in a semi-urban setting, so it is not too far from the city, but it's still a community type location. But yes, we definitely need to test it now further. Yeah, it would be interesting. What do you think?
We're going to be testing it in Phnom Penh in the city.
Oh, you are going to
Cambodia.
I see. That's what happens.
That's, I mean, yeah, because why certain people
Yeah.
need to have doctors come talk to them, you know.
Yeah, no, that's, I guess that's what you're going to find out.
And I think different cultures are different as far as what people will accept. Some cultures really want to have a medical professional there, and if they don't value it. Other cultures may be different from that standpoint. But another thing, I think back to an earlier question you said about, is it right to your country? Right now, until the program has more grassroots evidence and statistics and whatnot, it will be difficult for us to fundraise for it, and therefore it's going to be reliant on untagged donor funds kind of situations. But if certain countries, certain such situations, you can make that breakthrough quite early. We're not sure, I guess, right now whether the USAID or the WHO or UNICEF or others would really start contributing significantly to programs.
Well, we expect that they would, and this is an opportunity for ADO to reposition itself ahead of the curve and demand.
And that's, can I just say, so our health group, we really want to look at, do we have funding opportunities so we can invest in this now, in the belief that if we have like 5 or 6 countries that has already done the research in a year's time, that will make it such a stronger case that it's more than worth it. This is the last question, and then we will close, because I think by now, I don't know what happens here online, and then we can just talk afterwards as well. But the last question.
On the research.
Yeah.
I believe Cambodia has one chip group. Right?
Yeah.
Is that going into the main, or how is it being worked into the whole system?
No, so in our analysis, we separate. So when we are trying to look at a model, obviously we have to do that separately. Always when you have only one group, the numbers will be very low, but it is indicative still, so that they will get the feel of whether this is successful or not. Over time, if they do more chip programs, they will, they can aggregate that, or they can use the results from each of the regular chip programs and have a look. But it is actually not, you might compare, but you might also have better results in the city for various reasons, but it's still not necessarily the right program for the rural area. So it's like 2 programs with some similarity operating in 2 demographics. If you get the idea? So even if one was more successful than the others, it doesn't necessarily mean that you would want to swap. I think we need to close now. I don't know if anyone is still online.
Yes, we're all still here and very much enjoying all these questions and answers. Thank you.
So, any last questions from the online group, or do you want to just close off, Deborah?
I haven't seen any, so I think we'll just close off. I know it's getting later and later where you are, so we'll close off and let you all get some rest before your meetings start again tomorrow. Thank you so much, everybody, for attending, for your interest, for your amazing questions. We've got it all recorded, so if you have an interest in disseminating it further, we'll make sure this is sent out to everyone so that you can share some of this important research that's happening. And hopefully we'll be able to expand some of this important work into other programs in ADRA. Thank you so much, Pia, for all your hard work on this, and to the working group and everybody who's there. Have a wonderful evening.
Yes, thank you, and bye to everyone.
Bye.
Bye-bye.